Okay. So we're going to talk about a couple of the causes on the next slide, but it's important to think about constipation when you're treating your patients, and whether it's a temporary or chronic thing, because we do have a lot of different treatment options, and we've talked about this already with opioids, which is going to direct your treatment path quite a bit differently. If your patient's a chronic opioid user, that's way different than if they're having some sort of temporary constipation issue, which could be anything from an obstruction to just dietary changes or dehydration. So most drugs are going to act locally in the GI tract, so that's a nice advantage of giving laxatives in general. You aren't going to get a lot of systemic side effects with them. Now, of course, you can overdo it and flush out your GI tract, and then you can get electrolyte imbalances and disturbances. So, but if you're using them appropriately, they're relatively safe for most people. Most patient populations can take them. A lot of them are over the counter, which has its pros and cons, right? So you have people who will go out and take a bunch of laxatives because they don't really know how to dose themselves. They might not read the bottle correctly. They might not take enough. That's another thing that you'll get with OTC use as well. I feel like OTC labeling is always really conservative, right? If you ever had kids and tried to give them Tylenol or ibuprofen for a fever, you know that the dosing they give you on the bottle is quite a bit lower than what the max you could actually give them is. And we'll talk about that in pediatrics, but basically OTC labeling is always conservative. So maybe the patient's not taking as much as they actually could. Idiopathic etiology, sometimes it's just hard to figure out why somebody's constipated. You might have just slow colon transit time, or it could be even like a pelvic floor muscle dysfunction, and that could be a workup for a different type of provider as well. If you aren't comfortable with those types of muscle-related neuro connection type things, but that could be a Botox patient or something like that, or post spine cord injury could have something like that as well. All right, chronic constipation. So I've got some things on here, and I'm not concerned you guys know this for my class. It's just sort of for reference. And so we talk about these medications. You can put yourself in any of these patients' shoes. So again, anything from something like pregnancy, something like a diabetic patient. So all these patients are theoretically at risk. Some neuro stuff here. Parkinson's disease patients have higher incidence of constipation. So really, this touches a lot of different patient populations. And there's no really right way to treat constipation, but there are some general strategies that I'm going to hopefully give you here. Drugs. So drugs can certainly constipate people. We've touched on the anticholinergic drugs in general, which is pretty much where all these four fall into place. So our antihistamines, antispasmodics, antidepressants, and antipsychotics. If they're constipating, it's likely due to an anticholinergic component of the medication. Some supplements don't do great in the GI tract. Iron is probably the most notorious one. I'll give the story of my wife. She probably won't be really happy I'm sharing this with you, but when she was pregnant with our second, she got a little bit anemic, very slightly borderline, and they recommended she might. Well, actually, they didn't even recommend they take iron. They said, well, why don't we check it again, and then you could take iron if you're still low. And so she said, okay. And in her mind, she said, oh, I should go out and buy iron and start taking it. And all of a sudden, she's complaining that she's got this really bad GI distress. She's feeling like strong cramping. Not good. And so I'm like, well, maybe it's a pregnancy complication. We just didn't know. And then finally, I'm like, have you started taking a different vitamin or something like that? No, I was taking iron the last 3 days. Like, oh, well, there you go. I felt like the idiot pharmacist. I'm like, why didn't I come to that conclusion immediately? But I didn't even think about it. And she'd even mentioned it. She'd mentioned something about iron, and I was like, oh, I was like, I didn't think she told me she was starting it. So anyway. There you go. It's easy to overlook certain stuff like that, but supplements, definitely check out their supplements because they might have iron in them in a multivite or something and they don't know it. Neurally active agents, so this is just a category for some random stuff that they put together, but opiates, obviously a big one. Antihypertensives, not as huge of a cause of constipation. The rest of these I wouldn't think of them as major causes of constipation, so opiates certainly the big one on that category. All right, so education. Keeping the patients from developing a laxative dependency is good. So you don't want them to be dependent on using laxatives to have a bowel movement. So you want to try and get them back to a regular schedule. So you're taking advantage of some of the natural postprandial increases in colonic motility, usually highest in the morning, trying to get them to get on some sort of a schedule if they can. Harder for some people than others. Dietary changes, fiber intake and fluid intake. Those are going to be your two number ones to recommend people. So really, for the average patient who doesn't have an obvious cause for constipation, this is going to be your primary treatment. You can probably avoid drugs altogether, but certainly there are some medications that can help. I don't necessarily consider fiber a drug, but there's certainly products out there that are fiber mimics. So what exactly are they doing? You can certainly get fiber dietary, right, with fruits and vegetables. But it's recommended people take about 20 to 35 grams a day. And a lot of people don't eat enough fruits and vegetables or other like whole grains or anything to get there. So when you're looking at products, they're all pretty much the same. Is there a difference between Metamucil and Citrusol? Well, technically, yeah, one's psyllium husk and one's methyl cellulose. But they're both just insoluble fiber that you're ingesting. And there's really not a difference in how the body's going to react to it. It's bulk forming. So any one the person wants, if there's one that they like to mix in a drink and it tastes better, they prefer the wafer, go ahead. Again, I don't really care. There's no studies that, no one wants to do research on this because there's no money in it. So, and these products sell well without it, so it doesn't really matter. But I think that the point is the same, is that you're taking a certain amount of insoluble fiber on a daily basis to supplement what you're missing out of your diet. So again, lots of products, you can mix it or tablets or eat it as like a cracker or a wafer or something like that. Literature, again, very conflicting and then probably no difference. Side effects, pretty minimal should be, but it could cause some gas and cramping potentially, as you might expect. Surfactants, so surfactant should be not plural probably, there's really only one. Stool softener drug that's called Colace or Docusate. Colace is the brand name. Be careful using the term Colace because there's some different branding with Colace. Sometimes people, I think there's like a separate product that's Colace as well. So try and keep it as Docusate when you're ordering it. I've seen people mess this up before. And like it really matters that much, but you never know. Anyway, Docusate is a drug that's theoretically supposed to lower the surface tension of stool, allowing water to more easily enter it and loosen it up. So that it can move through. It has no effect on colonic motility. So if your colon's paralyzed or not moving, you're not going to do anything with this drug. So that's why you see Docusate combined a lot with a drug like Senokot, which we'll get to in a second, which is a stimulant laxative. Docusate has, I don't think, any known actual side effects that are attributed directly to Docusate. It's pretty much like drinking water as far as I understand. And in fact, the studies looking at it showed that it's inferior to bulk in one review that I found. So inferior to psyllium specifically, and has similar effects to drinking water. So I don't know if I think Colace is an actual good idea to do, but it's certainly not going to help somebody. Hydration status will probably be just as helpful as using Docusate. Osmotic agents. So these are poorly absorbed polymers and saccharides that cause intestinal water secretion, so pulling some fluid out of the body. This is where you can overdo it and cause some electrolyte imbalances. So that's the big deal with these. Again, compared to Docusate, you can't do that. With this, you can mess things up a little bit. So it's important to replace the fluids you're taking out. So like when you drink a Miralax, for example, you're going to take a capful and mix it with a certain amount of water. The reason is you want to be able to make sure the person's staying hydrated, and that should also help with the whole constipation component. Hopefully you aren't giving them diarrhea, right? All right, so polyethylene glycol is the major drug here that most people are going to use. That's what Miralax is, in its powdered form. People sometimes take it every day. I've seen people use it as needed. We'll talk about the time of onset for all this stuff in a little bit and compare that. It's kind of interesting, but we'll get to that in a second. The other product that you might hear of is something called Go Lightly or something similar to it. And essentially what it is it's polyethylene glycol with electrolytes added to it. And the reason is the electrolytes are supposed to absorb and help replace the ones you might be getting wasted due to the volume you're losing. And these are common for colonoscopy prep. So this jug is pretty big. You fill it up with water, and you have to drink it over a certain amount of time. And that's the standard colonoscopy prep you'll see used. You can also do it differently where you have somebody buy Miralax and drink it at certain intervals too. But this is kind of nice because it's a self-contained amount of volume, and you just drink it until it's gone. So it's pretty easy that way. Synthetic disaccharides are a little bit controversial. So lactulose and sorbitol are both used for this and have been used for this in the past. Lactulose has some other added benefits we're going to talk about with alcohol abuse in a few months here, I guess. But anyway, sorbitol is one that was used historically as a laxative. However, you get a lot of diarrhea, abdominal bloating, and these can actually cause pretty severe intestinal distress in people if you overdo it. Generally, they've fallen out of favor completely, so probably best to avoid them altogether. Saline laxatives are something like magnesium citrate, which comes as these bottles. You might see these on like drugstore shelves in the laxative section, and they are they kind of work similarly to the other osmotic agents, but it's basically poorly absorbed magnesium that's going to pull water into the intestine due to a kind of a concentration gradient system. You can absorb magnesium, although the formula is really poorly absorbed, so it's not really a concern for the average patient. If you have renal failure, though, when you take a whole bunch of it, you could potentially accumulate some extra magnesium, which could have some possible consequences. Rare, but not unheard of. You do see these used, the mag citrate combined with colonoscopy preps quite often, so they might do this plus a polyethylene glycol. That's a pretty common combination. Oh, this is my joke for the day. Have you ever heard of these? I don't know if this link still works, but there's really funny reviews about these gummy bears, and lots of funny question and answers. So if you want to humor yourself on Amazon, you can go check it out. These are gummy bears. So actually, they still make products like this that use these types of synthetic disaccharides. And why, I'm not exactly sure. I don't know if I've ever had the luxury of consuming any of these types of products, so hopefully not. But apparently you would notice it pretty quickly if you did. So yeah, you'll see sugar substitutes in some cases that are heavily disaccharide in nature that are going to cause systemic, or not systemic, but bowel effects that are not going to be pleasant for people. So anyway, they have a safety warning on the product now, but yeah, basically I think one of my favorite comments was, why get a colonoscopy prep when you can just sit and eat gummy bears at home? So there you go. Yeah. Stimulant laxatives. Okay, so moving on. So we talked about some ways to get more water into the gut, but those aren't really going to get anything moving. Yes, some of the drugs like polyethylene glycol, and especially like a Go Lightly prep, you're flushing so much fluid through, stuff's going to move, but you aren't actually making the colon move on its own. So stimulant laxatives are important for as kind of to balance that out. So if you're softening the stool or increasing water content, you still want to clear it out, and that's where these drugs can come into play. So bisacodyl is a product that is a tablet and suppository. The suppository is one of the fastest acting laxatives we have available to us. The rest of these all take quite a bit of time to work. It actually has corrected last year, so I should have updated this. I forgot about this until just now. But bisacodyl suppository is available over the counter. So, but I think the tablets are prescription only still, which is kind of weird. At least some of the strengths are for sure. So anyway, a little bit more potent than its partner in crime, Senna. Senna is an old drug that I don't think anyone really knows exactly how it works, but it does seem to increase intestinal activity. It's an effective medication. It's used commonly for opioid-induced constipation, specifically in the short term. So a lot of times, post-op pain management will be coupled with a Senna plus Docusate usually. And again, you have no reason not to couple it with Docusate, so you might as well give them the combination. It's going to cost the same amount of money, so there's no real downside to it. And if it softens the stool up a little bit more and helps it move through, great. If not, you're really not out any side effects or anything like that. Okay, so onset of action. I don't care that you know too much about this other than that it takes laxatives a fairly long time to work. There's not a good quick fix for constipation. And so the fastest you have are going to be suppositories. So again, a suppository of bisacodyl can be 15 minutes to an hour. Otherwise, oral onset, you're looking at least probably an hour. Magnesium citrate is the fastest oral onset medication. So if you're thinking about, I've got somebody here in urgent care and they're constipated and I want to give them something that's going to work fast, but I don't want to give them a suppository, that's probably a drug that'll work relatively quickly compared to some of the other ones. But still, you're looking at maybe a couple of hours as not uncommon for response. So again, not a quick fix. And a lot of these drugs are really variable. So you take Senna, and are you going to get a response in 6 hours or 12 hours? Well, that's a pretty big window of time to think about maybe having a bowel movement. So it can be inconvenient for the patient. So I would say that if somebody takes one of these medications to know that they have this variable response and not to be surprised if it doesn't work right away. Some people might end up taking a lot more and then they kind of overdo it, and then they get a lot of misery on the other side of that, right? So that's just my words of wisdom. We're going to talk about these two drugs in a second, so don't worry about those quite yet. And by a second, I mean this slide apparently. So both both of these are newer agents, and they're a little bit more expensive. They came on the market, I feel like lubiprostone actually has been around quite a while, so maybe it's going generic soon. But both of them are still much more expensive than your average Senna or Docusate or Miralax product. And these are designed for chronic idiopathic constipation. So really there's no known source. We don't know what's going on, but this person is chronically constipated, so we're going to try one of these drugs. Linaclotide or Linzess is a minimally absorbed peptide agonist, so it causes increased intestinal fluid secretion and improved transit. So it does have some bowel stimulation properties, and it kind of acts like a polyethylene glycol, where it pulls water in or fluid into the intestine. It's dosed once a day. It's a brand-only medication. Amitiza, lubiprostone, is a locally acting chloride channel activator, and this has a similar effect. So the chloride channels, when activated or agonized by this medication in the GI tract, cause increase in intestinal fluid secretion, which is chloride rich. I'm not sure if that helps stimulate things to move or not, but that's just part of the mechanism. I don't really know exactly why that's important. But similar dosing, once daily, brand name only. It has some dose-dependent nausea associated with it, which is what you'd expect for any medication that's altering how the GI transits. You're probably going to get some nausea, especially after you first take it or it first kicks in.
So is linaclotide then preferred to?
I don't know if they've done any trials head-to-head comparing those two, if they're going to be preferred or not. From what I've seen, I feel like linaclotide is a much more popular product, and I don't see as much lubiprostone prescribed to the patients coming into our hospital, but that's just an anecdotal observation. Yeah, I don't know. I would say you could try one, and if it doesn't work, try the other one. They're slightly different, so you might get different responses from patients that way, but they should have fairly similar effects, I would think. All right, severe constipation. So suppositories and enemas are going to work faster than anything taken PO. I didn't talk about Fleet's enema. Yeah, so Fleet's enema hasn't come up yet. Fleet's enemas are another option, and so are some other different types of enemas. There's mineral oil, saline, warm water enemas. Be careful of recommending these to people unless you have a good foundation for doing it. They can kind of cause some irritability, or you can get some electrolyte disturbances with them as well if they're changing concentration gradients and pulling fluid out. But sodium phosphate enemas are relatively safe. These are over-the-counter. Fleet's products come in a bunch of different formulations. So if you tell somebody to take Fleet's, make sure you tell them the sodium phosphate kind or whatever intended kind, because a Fleet's brand could have saline enema. It could be a mineral oil enema. You don't necessarily know. There's 12 different Fleet's products on the market. But the historical Fleet's is the sodium phosphate. And these are generally okay for most patients, but people with poor kidney function. People with poor kidney function will retain quite a bit of phosphorus off of this product. And that's, of course, we talked about that during renal a little bit, so you can go back if you're rusty on that. But the complications for an elderly patient or a renal patient, involving things like EKG changes and stuff like that, potentially with really high phos levels, are something we want to avoid. So again, healthy patient, good kidneys, fine, no issue there. They're just going to eliminate whatever extra phos they absorb. But for the complicated elderly patient or the renal patient, just avoid it in general. Some other options, misoprostol. We're going to talk about misoprostol a lot. Well, not a lot, but in more detail when we talk about OB. It's got some more roles around postpartum hemorrhage, and it's really not useful in this area. I don't think I've ever actually seen it used for constipation. But theoretically, you could combine it with polyethylene glycol. It's a prostaglandin analog that can help the GI move things along a little bit. It tends to work locally in the GI that way. It's also got some NSAID-like properties, which is kind of interesting. Anyway, we'll talk about it more during OB. It's got more applications there. I think it makes a little more sense to discuss its mechanisms there. But anyway, kind of an oddball. Colchicine actually has been shown to affect dietary, or not dietary, but bowel movement as well. And it might be effective, but likely not a good use of this medication in most cases. But certainly for somebody who has tried everything else, it could be an option. Botox, this would be for a pelvic floor muscle issue, so somebody with maybe some spinal cord injury or some sort of neuromuscular dyscommunication there. And colectomy, and we'll talk about that. Would be, of course, a severe case of something that you can't fix any other way. Okay, treatment summary. So underlying problem is going to be your biggest one, and then your first strategy is your diet, your hydration, and your fiber supplementation if needed. So talk about those things, and if you're still not really coming to a consensus on what's causing the constipation, or the initial strategy of diet's not working for your patient, that's where you try your osmotic or stimulant laxatives plus minus your surfactant. And then if that doesn't work, you'd move on and try maybe some of the newer agents like Linzess or lubiprostone, or if Botox was applicable, you could refer them for that, or possibly misoprostol as well if it's severe. So there's some extra options there, but you don't really have much to work with these outside of kind of the basic stuff. Yeah.
Did you say that taking surfactants or like staying hydrated is just as good as taking surfactants?
Based on the evidence I've read, yeah, it doesn't seem to be all that much more effective than water.
So when would we want to use surfactants?
Yeah, I think you could recommend it if somebody's constipated to try it. It might give them some benefit. Maybe. Yeah, I would just recommend they drink water at the same time. So who knows what's going to help them better, but certainly, if you're thinking that stool's hard, it might help soften it up so it can move through easier if you're going to use a stimulant laxative on top of it. So theoretically, it makes sense to combine them. In clinical practice, I don't know if you get the best benefits from surfactant. But yes.
Talk a little bit about not developing a laxative dependency. Are there certain drugs like the stimulants that your bowel would become more dependent on than like the osmotics? Or
I've heard everything. I've heard people who claim like a dependency on DocuSafe before, where they take like 10 to 15 DocuSafe a day.
Oh.
Now, whether that's actually just more of a psychological thing at that point, I'm not 100% sure. But yeah, I mean, if you're getting, I think it'd be more like the stimulant laxatives or the more potent things like a Miralax, where they're doing it every single day, multiple times. I think I've seen plenty of patients who do do a Miralax every morning, and I don't know if I'd say there's anything wrong with that. Is that dependence? Is there a problem with that? It's a clinical toss-up at that point. Are they doing it multiple times a day? Are they making tons of senna on top of it? What point do you intervene on that? That's going to be a clinical decision I can't answer, but yeah, I think the idea is that if your patient's doesn't have any sort of problem that you can easily address or fix, and that you seem like dietary would work for them, that's the goal, is to get them to have sort of a more natural response. That's going to be the best, but if it doesn't work, it doesn't work. So, yeah.
Do you know anything about using laxatives for weight loss? Is that more of an abuse?
Yeah. So that would be intentionally using it so you're not absorbing the calories, and and that would be different than dependence in this case, but yeah, that could be certainly a form of abuse. All right, switching gears. So diarrhea. I was curious where the word came from, so I thought I'd share it with you guys. I don't think anyone really cares. So this is going to sound a lot like constipation, but just obviously flipped. So acute versus chronic. This is sort of how they define diarrhea and chronic versus acute. So if you've been over 30 days of diarrhea, that's chronic. Seems like a long time to have diarrhea. But the point, I think, is that usually something that's infectious in nature, the common causes of diarrhea, are going to resolve on their own within a couple of weeks, hopefully. So food poisoning, which would be like salmonella or something like that. Stomach flu, which is a term I hate. It's not actually influenza, right? It's norovirus or something like that. But all the viruses that affect the GI tract, rotavirus, those types of things. Generally going to self-clear within a couple of days, if not, maybe a week. Some of these might last longer, like especially the bacterial ones. Like salmonella could be a little bit longer than that, but the viruses are usually going to be very short-lived. Not comfortable at all during that period, but short-lived, fortunately. Medication-induced can cause diarrhea as well. It's more common for medications to constipate people than cause diarrhea, but certainly possible. And illnesses related, so GI illness, certain types of cancers can cause, usually GI-related cancers can cause diarrhea as well. There's a whole criteria, and I'm going to spare you guys pictures and things that I found on the internet when I was originally looking at this, because there's like a whole criteria about stool consistency and how you should treat based on it. So anyway, if you're curious about that, you go to like Up to Date or something and look at their pictures, but I don't really care about that. So I'll let you guys do that on your own time. Okay, rehydration. So similar to constipation, different reason though, we want to rehydrate because the person is losing electrolytes during their diarrhea. So that's pretty straightforward. Solutions with salt, water, and sugar I think generally are good if people can stomach them. You're probably not absorbing a lot of calories, so I think a little bit, unless your patient's really obese or highly diabetic and uncontrolled, I don't think a little bit of sugar would be problematic for the average patient. So something like Gatorade should be fine. Pedialyte has a lot less sugar in it, and it's a bit better as far as the electrolyte component to it. So if your person wants to drink it, I think Pedialyte tastes kind of gross. Personally, I've tried it when I was sick before, and I prefer just something else. But anyway, some people might find it that it makes them feel nauseous because it does taste kind of salty, I think. And anyway, IV hydration would be for really severe cases. So somebody can't keep anything down, really bad diarrhea, that's where you do IV hydration. Assess the need for antibiotic therapy. So this would be one of the things you're going to test if somebody comes in with a new onset diarrhea and they're not exactly sure what the cause is. We want to make sure that we're ruling that out, specifically C. diff. So if they've had a C. diff exposure recently, that's going to be a big red flag, and you definitely want to get that stool cultured and make sure you're testing for that. The other forms of bacterial infection are mostly self-limiting. So we talked about this last fall, so I'm not going to go into it again. But a lot of them we don't do anything for. If you are going to treat fluoroquinolones like Cipro and macrolides like azithromycin are usually effective for most enteric pathogens. Obviously not C. diff, that's a different oral vanco or oral metronidazole. Viral infections, there's nothing to do. You replace fluids, they're short-lived, they'll clear themselves on their own. Diet. The diet brought or bananas, rice, apples, and toast is something that is an acronym used to talk about easy, bland, soft, easily digestible foods that you can theoretically reintroduce after somebody had a bout of diarrhea. So the idea is it doesn't have to be these foods specifically, I don't think, but these are easy on the GI tract. And if you are going to recommend somebody introduce foods gradually, these have been shown to be relatively benign for most patients. Most patients can stomach these. There are other things too that people could try, but I think the whole point is to gradually reintroduce stuff and make sure you aren't all of a sudden going out and eating like a super huge like Chipotle burrito right after you've had a huge bout of diarrhea. Maybe not the best thing to do. But if you're starving and you can stomach it, I guess, who am I to tell you not to do that? Okay. We talked about loperamide, we talked about Lamodal, so these are opioid related. We talked about opium tincture already, so we kind of covered this stuff already. These are opioid related drugs that help stop the GI tract from moving. The controversy with using these is that if you have some sort of infectious pathogen on board, you could end up worsening your problem. So the idea is that if you have any type of infectious disease, you just want to let the body do its thing and do supportive care. You don't necessarily want your body to be storing a bunch of bacteria within the GI tract because you paralyzed it and can't move it through, and now those bacteria are making toxins, and that's causing additional issues. So overall, I think if it's infectious in nature, you just let it go. But if there's something else causing it, certainly you could try some of these medications. So fever and dysentery would be the two kind of diagnostic clues that would make you want to probably likely avoid any type of anti-motility agent. Pepto Bismol is something that, or bismuth subsalicylate is the actual drug. It's not as effective as an opioid-based medication, but it has some antimicrobial and anti-secretory activity. Some people take this as traveler's diarrhea prophylaxis, but you have to take it with every meal, because that's when it's going to work best, is when you're absorbing something and possibly exposing yourself to some sort of a pathogen. But it should work also for just average symptoms too. They advertise it as working for like everything, but this is kind of where it might actually help somebody is if they have diarrhea. It is contraindicated in pregnancy in children. It's got an aspirin moiety potentially, so it's got that salicylate component to it. And it can cause darkening of the tongue and grayish black stool. So if somebody's taking it and they get surprised by that, that's something. If you're going to recommend them prophylax with Pepto Bismol while they're traveling to some other country, just maybe give them a heads up that their stools might look kind of strange. Probiotics. Probiotics might be effective for a variety of mild diarrhea-related illness. However, there's not a lot of good evidence or information about them, and there's specifically no positive evidence for probiotics in more advanced cases. For example, they've looked at probiotics in C. diff cases a lot, and there's no evidence that says it improves C. diff, unfortunately. Because it'd be an easy thing to do. You give somebody yogurt or have them take it. We actually ban these from the hospital because there's not enough evidence to support using them. And probiotics in like a capsule form, if they get aerosolized, could potentially cause an infection in an immunocompromised patient. Rare and odd, but it's possible. So anyway, there's an excuse for us to get rid of them because there's not really a good reason for a hospitalized patient to take them. Now, if somebody wants to take these on their own at home, or eat yogurt every day, or drink kefir or kombucha or whatever, that's great. It might help their GI flora and maybe prevent certain things, or again help with some mild diarrheal-related illness. But ultimately, for severe complications, there's no evidence that shows that these work. Okay, prokinetic agents. So what do we do if we really want to get this moving? For gastroparesis, some causes you might see are delayed gastric emptying. So you might not have a necessarily obstruction there, but there's, for some reason, the stomach's not emptying appropriately. So it could be some sort of post-surgery, or maybe the person's been really sick for a while. Who knows what's going on? That could be a number of things causing it. Major symptoms, people are going to be nauseous, vomiting. They're going to feel full earlier, bloating, upper abdominal pain. This can be difficult from a dietary perspective too, because glycemic control, blood sugars can be all over the place, and hydration status is something to look at too. So those are kind of the things I'm not going to talk about more than I just did, and we're going to look at a couple of drugs that can help the GI tract move if there's an issue where for some reason it's not moving appropriately. A lot of these drugs, well, this drug in particular is an antiemetic. So metoclopramide or Reglan is a popular antiemetic. So we're going to talk about that in the next slide set. But what it does is it works as a dopamine receptor antagonist, and I'll get into this mechanism during the antiemetics and talk about that in a little more detail. But it enhances response to acetylcholine in the upper GI tract too, and it enhances motility and gastric emptying. This is one of the first lines for gastroparesis. Its side effects are pretty minimal. We're going to talk about things like EPS, dystonias, and Parkinsonian-like reactions when we talk about antipsychotics, and I'll bring them back up during the antiemetics lecture too. But a lot of the antiemetics we use have a history as psych medications, or at least structurally they're similarly related to some of our antipsychotic medications. And antipsychotic medications historically cause something called extrapyramidal symptoms, which is movement disorders. So tremors and sometimes gait disturbances, things like that. Usually it's short-lived, it's reversible, you stop the agent, and it's not a big, long-lasting complication. But just to know, it is possible with a drug like metoclopramide, although really, really rare. I don't think I've ever actually seen or heard of somebody reacting to Reglan because of this. Not that it hasn't happened, but it's odd, and I've seen a lot of Reglan get dispensed, so it's just not a common reaction. Other drugs, it does happen quite often, not this one, but it is theoretically possible. Erythromycin, the antibiotic, is actually a pro-motility agent. It agonizes the peptide hormone motilin, which improves the ability of the GI tract to utilize that hormone and then therefore move stuff through. And it stimulates fundus contractility. Disadvantages, it's dosed 4 times a day. I think, did I say what Reglan was dosed? Reglan's usually dosed twice or 3 times a day. So you've got one more. So QID dosing is a little tricky for most patients. And the oral liquid is usually preferred, and that's the one that's generally studied for gastroparesis, as opposed to like capsules of erythromycin, like the antibiotic would generally come in. The oral liquid for erythromycin, for whatever reason, is like $1,000 per bottle. So if you're ever thinking about prescribing it and some pharmacy calls you and says, this is really expensive, don't be terribly surprised. I don't know why. I don't think anyone else makes it. I think it's got such a limited market use that no one wants to make it. So the one person that does charges whatever they want for it, which is the great world of drugs we live in. Problems. Tachyphylaxis, so it can just stop working suddenly. Maybe somebody's getting great response, then all of a sudden it doesn't work. You get bacterial resistance potentially. It has some GI, ototoxicity, QTC prolongation is possible. Taking an antibiotic for long term that wasn't originally designed to be used long term is always a little bit complicated. So you don't necessarily know what you're going to get. So ideally, you'd get by with Reglan and you could avoid this, but it is an option for some patients. Azithromycin has similar promotility effects as well, but it is still somewhat useful in some antibiotic indications. So ideally, we'd use erythromycin. Erythromycin doesn't have a huge role in infectious disease anymore, so you aren't really too worried about stuff getting resistant to it, but there's always that possibility you could get additional macrolide resistance from exposure to erythromycin. Okay, we're going to talk about some other antiemetics in the next lecture. And basically this involves the nauseous component of this. It's not necessarily like these drugs. Like antihistamines probably aren't going to get the GI tract moving, but they can be used as an antiemetic. So that can be helpful for the symptoms, but not necessarily for the underlying cause. Some other options, tricyclic antidepressants are an old class of antidepressants that can have some promotility properties to them as well, which we'll talk about more during the psych lectures. And surgical or procedural options could be a possibility as well. All right, let's take a 10-minute break and come back and we'll talk about antiemetics. Oh yeah, yep.
Could constipation happen from that, or would you need to be taking it more days?
I think it can happen from even a small amount of iron. Iron's not very well absorbed, so it stays in the GI tract, and I think I wouldn't be surprised if somebody got it even
So
from.
it could happen even just from 4 days.
Yeah,
Okay.
yeah.
Mm-hmm.
What's really expensive in a PO form?
The PO liquid, so like the liquid suspension is preferred for the treatment because that's what's studied to be effective, but it's also really expensive. So like compared to just regular capsules, which are pretty cheap. Yes, but the tablets are prescription, yes.
People are it's just magnesium itself.
You could, yeah.
Magnesium citrate.
Yep, people have taken like magnesium oxide as a tablet form of magnesium too, and you can get diarrhea from that too. So you could take that as a laxative on its own. Yeah. Mm-hmm.
And this is just different because it's like different.
Citrate is a less absorbed form of magnesium than some of the other ones on the market, so that's why it's specifically used as a laxative and not necessarily as like a supplement. Whereas something like magnesium oxide is the common tablet one that's over the counter. You're going to absorb a lot more of that, but it will still cause a laxative effect as well.
So you're not supposed to use this. You're not. She knows that. Oh, no, I did not study much. Yeah, she was like, oh, my doctor said not to do
You did that all? I feel like it's something you have to do.
Are we doing all four pumpkins?
No, I'll get through the next one for sure, and probably some of the antacid one. I don't think we'll finish antacids.
Okay.
Did you
Huh?
like it? Not doing it?
No, that's a kind of a long one on its own.
No, because I
Oh, yeah.
Right. But